Now shifting from retina to cornea, Dr. INDU Pandey ma'am will be talking about corneal causes of unexplained visual loss.
So a very good afternoon to one and all. I would like to thank AIOC and Dr. Nagendra sir for being me here. So I would be talking about cornea as a cause of unexplained visual loss. As we all know, cornea is kept in a relatively dehydrated state, and it plays an important role in focusing light onto the retina. So any disruption in the cornea's structure or function relatively or adversely affects the faculty of vision. So few causes like corneal edema, drying of the cornea, degenerations, dystrophies, inflammation, infection, vascularization, and scarring of the cornea, all are responsible for loss of vision. So I would be discussing few cases of mine. So this is a case, a 40-year-old female presented with a recent onset of diminution of vision along with mild pain while the patient was already on oral acyclovir 400 milligram twice a day. So on clinical examination, what I could see was stromal infiltration with inflammation and underlying KPs. There was mild edema also, and the patient was diagnosed as a case of HSV immune stromal keratitis. Now the questions that we need to address is what should be the frequency and how we should taper the steroids, and whether to step up oral acyclovir or to start with the topical, and why did the patient had this recurrence while still on prophylactic antivirals. So the recurrence of the disease is seen in 50% of the cases within 6 weeks of cessation of steroids. Now, once a patient comes to you, what are the features that you should look for which will aid in the diagnosis of HSV immune keratitis? So you should always take a thorough history, ask the patient about the previous episodes, look for the presence of the footprint scars or the ghost figures, look for the vascularization or the ghost vessels. However, corneal sensation is a variable sign. It might be present or might not be present. Now, how do we manage this case? We have to start this patient on oral prednisolone 8 to 10 times per day, and then taper gradually on a weekly basis till a dosage of 4 times in a day is achieved. And during all this time, the patient has to be kept on oral acyclovir 400 milligram 5 times in a day. Now, further tapering has to be very slow, and we can go up to alternate day therapy or even twice or thrice in a week. And if you have a patient who has repeated recurrences, then we can even think about switching the patient on a weaker steroids. Now, this is case number 2. The 35-year-old female came with a history of pain, watering, foreign body sensation, and photophobia. The clinical features that I found was that the lesion was in close proximity to the limbus. There was accompanying blood vessel and anterior stromal infiltrate underlying the ulceration, and the lesion was showing central progression. So the diagnosis was HSV marginal keratitis. Now this is because of the active viral disease, and the patients tend to be more symptomatic, and it is more difficult to treat than a central dendritic ulcer. Now this disease, the HSV marginal keratitis, needs to be differentiated from the staphylococcal marginal keratitis, which is an immune reaction, and it shows a special predilection to 2, 4, 8, and 10 o'clock position. There is usual association with the staphylococcal the blepharitis. The lesion shows circumferential spread, and to start with, it is just a stromal infiltration. The epithelium remains intact. And the treatment of staphylococcal marginal keratitis is with steroids, as we all know. But if in a case of viral marginal keratitis, if you prescribe steroids, then it leads to worsening of the condition. So an important DD is staphylococcal marginal keratitis, which always have to be kept in mind. Now, this is a very old patient of mine. He was a 12-year-old boy who would come to me repeatedly for repeated consultation. He had the problem of itching and was diagnosed as a case of VKC. After a few consultations, he started saying that he was not happy with the vision. He was able to see, but the vision was distorted. And even after giving repeated correction with the glasses, he was not comfortable. So what I missed was an underlying keratoconus, that had already developed. So the clinical features that we should look for is that the disease typically present in the teens or the early 20s. The patient complains of progressive blurring or distortion of vision, requires frequent change of glasses. There is accompanying photophobia and glare, which is typically worse at night, monoocular diplopia, ocular irritation, and itching. Now, few clinical signs which you can see on torchlight examination are Munson signs, Ridgety's sign, all droplet reflex sign. All these signs are seen once when the disease is well established. Now, on clinical examination, what we see is the presence of ectasia and thinning, the presence of Fleischer's ring. Apical scarring, if present, suggests that the patient has had breaks in the Bowman's membrane. Descemet membrane level scarring suggests previous history of hydrops. Prominent corneal nerves, especially in the periphery, are seen, and we see vogued stria, which are parallel lines seen in the posterior stroma, and they typically disappear once you apply pressure on the globe. So to diagnose a case, the corneal topography is the best modality. In the map that you get, you have to see the symmetry between the upper and the lower half of the map. The symmetry is usually gone. In the central cornea shows more steepness and the thinning of the central cornea. If you are finding these three signs, then your diagnosis of keratoconus is made. Now in keratoconus, how do we treat? In a non-progressive case, we can put the patient on glasses or contact lens, and if the patient is intolerant to contact lenses, then we can go for Intacs, and in advanced cases, PK or DALC is the treatment of choice. In all those progressive cases of keratoconus, collagen cross-linking is the answer. Now, these are few surgical options. Now, this is the most important slide. When and where do you have to suspect keratoconus? So the age of presentation is very typical. It is usually presenting in the teens and early 20s. In all those cases wherein you level the patient as a case of anisometropic amblyopia, you have to first thoroughly check for keratoconus. In all those cases wherein you have high myopic astigmatism, in which the cylindrical power difference between the two eyes is more than 1.5 diopters, these cases are to be screened. Then the scissoring reflex is the first sign that you see on retinoscopy. The presence of Fleischer's ring, which is best seen in cobalt blue filter. It is brown color discoloration present at the base of the cone of the keratoconus. Then topography is the modality of choice for knowing the progression of the disease, and the treatment of choice is cross-linking. So this is my fourth case. The patient in her 50s came with a complaint of early morning decrease of vision, which gradually improved as the day passed. The patient was diagnosed as Fuchs' endothelial dystrophy. It is characterized by presence of corneal gutta, which are seen as black spots on direct illumination and give a dewdrop-like appearance on retroillumination. To start with, they are present in the center of the cornea and gradually the cullis, and give a silver beaten metal appearance. In stage 3, wherein you have stromal edema, they will give present as microcyst and bullae, and stage 4 is characterized by subepithelial fibrosis. So the treatment of choice is with the hypertonic saline drops and ointment, dehydration of the cornea, beta blockers, bandage contact lenses when the bullae is ruptured and the patient is in pain. The other options could be DSEC and DMAC in the later stages. Now, what if a patient of Fuchs comes with cataract, then how you should approach such case? Now, the goal is always to protect the corneal endothelium. Pre-operative counseling of the patient has to be done. The patient needs to be explained that patient might require a further corneal surgery. Now, there are few steps that you have to take intraoperatively so as to preserve the corneal function of the patient. Use of the dispersive viscoelastic, removal of the cataract in the bag. Limbal incision should always be made keeping the tunnel short, because you don't want your incision to be on the way of the future DSEC flap. You have to stay away from the endothelium, use less of a power, use less flow rate. Now, supposing you are keeping a flow rate of 40 cc per minute and considering the volume of AC to be 1/4 of a cc, you are turning over the AC 160 times in a minute. So that is quite a turbulence. The normal corneal tissue will rebound back to it, but in Fuchs patients, they don't, and they manifest as corneal edema. So you should always try to keep more of vacuum, use single piece acrylic lenses, very light hydration of the incision needs to be done, and you have to remove completely the visco that you have put. Thank you all.